Okay, so welcome everyone. I'll quickly introduce myself. My name is Jaya. I'm the CSR lead at NATHEALTH. And on behalf of our team, I extend a warm welcome to you as distinguished speakers, moderator for this webinar on elevating patient safety, best practices in hospital safety audits. Your expertise in the field will undoubtedly enrich our discussion and contribute to the success of this important event. We are eager to delve into this crucial topic of hospital safety audit, exploring best practices that play a pivotal role in enhancing patient safety. We are honored to have industry stalwarts like Dr. Shabnam Singh, Dr. Sunil Khetarpal, Dr. Bansidhar, and Captain Sandhya with us today, whose collective expertise will enrich our discussion. Thank you, everyone, for being an integral part of this initiative. And we really look forward to an enlightening and engaging webinar. Now, I quickly go through the bio of our moderator, Dr. Sunil Kumar Khetarpal. Sir is a director at AHPI with nearly 35 years of rich experience. Dr. Sunil Khetarpal is an expert in healthcare management. His expertise spans a wide range of fields, including hospital administration, clinical and non-clinical operations strategy, and policy development. NABH and quality accreditation, education and training, digital health, medical legal issues, advocacy with government. He is an effective and enthusiastic speaker, panelist, and moderator at various regional, national, and international events. I'll quickly move to Dr. Shabnam Singh, ma'am. Dr. Shabnam Singh, ma'am, is a principal advisor, Healthcare Confederation of Indian Industry. At present, Dr. Shabnam is an alumnus of Lady Hardinge Medical College, Delhi, and has 4 decades of rich experience in healthcare, spanning across roles as practicing clinician and administrator. Her strength lies in skilling and capability building, education, understanding of physician behavior, and nuances of operationalizing healthcare delivery system in resource-constrained environments. Nationally, an active member of CII, NABH, and contributor to task forces on AI, digital medical technology, health insurance, and costing of service, public health policy, and governances. Thank you, ma'am, for joining us today. I'll move to Dr. Bansidhar Tarai. Thank you, sir. Dr. Bansidhar Tarai is Associate Director and Head Microbiology, Molecular Diagnostic and Infection Control at Max Super Specialty Hospital, Saket. He's also the co-chair and coordinator for microbiology and infection control service offered across Max Group of Hospitals, and MD in medical microbiology from PGIMR Chandigarh. Dr. Tarai is an active member of the infection control team and plays a leading role in developing and implementing antibiotic and infection control policies for Max Group of Hospital. He has more than 50 index publications, 7 non-index, and 6 book chapters. He is the recipient of several prestigious awards for significant his contribution towards infection control and patient safety. Healing Hands Award 2015, 6th International Patient Safety Congress 2016, ABP News Award on Patient Safety 2016, Max Healthcare Susruta Award 2018. So, sir has a lot of work around patient safety. Thank you, sir. Thank you for joining us today. Finally, I'll move to Captain Sandhya Sankar. She's the Corporate Chief of Nursing at Fortis Healthcare Limited, heading Nursing Vertical, Medical Strategy, and Operational Group for Fortis Healthcare Network of Hospitals and Network of 28 hospitals. She has over 27 years contribution to military nursing, industrial and corporate healthcare quality assurance, and leading large team of more than 6,000 personnel. Ma'am has NABH and NABH Nursing Excellence Quality Council of India faculty and principal assessor role. She has received various prestigious awards and recognition as Women Super Achiever Award at the World Women Congress in 2020, National Health Care Women Leadership Award in 2019, Max India Chairman's Award in 2016, Chief of Army Staff Commendation Card for contribution toward towards Bhuj earthquake in 2002, General Officer in Command Commendation Card Operation Vijay at 92 Base Hospital, Srinagar, General Koreapa's Medal for Best All-Round Outgoing Nursing Officer at AFMC 1998, KS Masters Medal for scoring distinction in all subjects in undergrad stream in Pune University 1998. Thank you, ma'am. Thank you for joining us today. Now, I would like to pass the baton to Dr. Sunil, who will guide us through the session as a moderator. So, Dr. Khetarpal, the floor is yours now.
You're on mute, Sunil.
Yeah, thank you. Thank you, Jaya. And thank you for making us a part of this great initiative taken by NATHEALTH. And I am delighted to extend a warm welcome to each one of you for the significant session, which is focusing on enhancing patient safety, best practices in patient safety audits. So today we are here, with a shared dedication and a common objective, ensuring the safety and well-being of our patients. Now, if you talk of patient safety is fundamental to healthcare quality and is a non-negotiable priority and a commitment to the well-being of our patients. So there is a need to foster a culture of patient-centric care and forge a more dependable healthcare system where safety should be a paramount. And also patient safety is an inherent responsibility that healthcare providers and organizations must uphold. So this session is dedicated to comprehending the best practices and elevate patient safety through audits. And healthcare landscape, we all know that it's constantly evolving, and it's imperative for us to stay informed about the best methodologies, technologies, and strategies, and that contribute to secure patient experience. And hospital safety audit, when we are talking of, it plays a crucial role in ensuring a safe and secure environment for patients, not only for the patients, but for the staff, for the visitors, and all stakeholders, all those who are visiting the hospital. So implementing best practices in hospitals, and identifying and addressing the potential risk, complying with regulation, and continuously improving the safety protocol is the key. So I'm sure we will benefit from the insights which are going to be shared by our expert and esteemed panelist. I have a very learned panelist with me today, and their perspectives will surely enrich our understanding and will offer valuable insights into how we can collectively enhance the safety measures in our hospital. So I extend my deepest gratitude once again to NATHEALTH, especially Jaya, who has been coordinating with us, our distinguished speakers, and each one of you who are present here as the participants to contribute into this discussion. So we will take up the questions at the end of the session, or if anybody has any question, he or she can put the question in the chat box as well. So without further delay, let us commence the session. And I have an honor to invite Dr. Shabnam Singh. And Dr. Shabnam Singh, we all know she's currently working as a principal advisor to health policy in CII. And she had been my mentor when we worked in Max. I was working under her. She was my mentor, my guru, and today we are here on a common platform. So it's a pleasure and honor to have Dr. Shabnam Singh as a first speaker. So Dr. Shabnam Singh, over to you. You may share your valuable insights or your viewpoint on the topic, on the subject.
Thank you so much for your very kind words, Sunil. And thank you, NATHEALTH and Jeff, for organizing this very important and marquee event. So I'll just share with all of you a bit of a historical perspective on patient safety and audits, and perhaps given the evolving landscape and the expansion of the stakeholders in healthcare delivery, a little crystal ball gazing as to where we are in patient safety. So as Sunil very well encapsulated, the objective of patient safety audits is essentially to assess and monitor the quality of care provided to patients within healthcare settings to ensure their safety and well-being. So clearly, they are conducted to identify areas of improvement, assess their compliance with regulations, best practices, and minimize the risk of adverse events that would compromise patient safety. Now, when you look at all of this, this is in a closed environment of the hospital. Having said that, what it does not address is what happens once the patient gets discharged. The entire patient safety, however, is looked at from the lens that the patient, after coming into the hospital, undergoes an intervention, is admitted, and then goes back. He goes back as a whole human being who is fit for purpose, fit for living, fit for job, whichever environment he is. So actually speaking, this goes beyond the guardrails of the hospital, and that is something that the ecosystem is now thinking about. So I'll divide my comments in two buckets. One is the traditional area that we look at, and that is in the closed environment of the hospital. So from a patient perspective, it's very clear why. From a hospital perspective also, it has to be understood. It's extremely important that they focus on this, because the last thing that they would like is that a patient gets readmitted and thereby the costs of care go up, and by that the institution also gets a negative impression. Dr. Bansidhar, I'm sure, is going to address this. Acquiring hospital infection, the HAIs, is again not in the interest of the institution. So clearly, if you see it from the traditional perspective, the audit serves several purposes. Evaluates compliances, it identifies risks. Then you'll have improvement in processes, monitoring of the performance of the hospital, enhancing patient experience, and I'll circle back on this enhancement of patient experience, and prevent adverse events. So this is the historical perspective of the audit. Now, when you look at the audits as they are done, these are done, monitored by in-house committees, right? And they're monitored by a vast stakeholder set, but again, they are principally all representative of the hospital. The challenges, however, in patient safety come about when there are communication breakdowns, right? Even in our homes, when you communicate with your staff, with your family members, how many times will your child turn around and say, I don't understand what you're saying. You are not looking at it from my perspective. This gets expanded even in a hospital. More specifically, how does this impact? This impacts a very, very important piece, which Sandhya will address, I'm sure, later, is in medication errors. If you do not explain to the patient properly how to take the medicine, and very importantly, the caregiver who's going to give that medicine, these errors are going to continue not only in the hospital, but even outside the hospital. Technology has given us a very powerful lever to be able to take care of patient safety, right? But how do you use that technology? It has the latest. We all have phones, ubiquitous mobile phone. How many times in a week do you update your software? The same thing applies to every piece of equipment in the hospital, right? This is another very, very important area. And then you will be told by a patient, I tried to get back to you, you did not pick up, I sent you my reports, you could not download the reports, therefore you could not give back the right information to the patient, and so on and so forth. I could go on this. Staffing pressures, the fatigue factor in staffing, the breakdown when you are not able to have the requisite number of people just because there has been an unfortunate intervention like COVID. Adherence to best practices and protocols. All of this is technology driven. So you punch it in. Dr. Bansidhar will know the reports are uploaded. You're punching it. Instead of putting a plus or a minus, the person is so tired, the wrong one goes. And then you realize so often that there will either be a gender issue, a date issue, because the person is extremely tired or it just does not know the right way of data entry. Today in hospitals, you have innumerable amount of data. The problem with the data is how do you make sense out of the data and how do you then use the analytics on it? Then comes very fundamental things, hand hygiene and infection control, right? As I said, Dr. Bansidhar will bear me out in this. Patients' relatives come. COVID was a great eye-opener to them, but how many are still following it when they get into the lift? Hold on to the guardrails. They've come in to see the patient. Beta kaise ho, and that cheek is rotated like that. Simple things like that all add, but they're not captured in an audit, right? So how are you going to address these challenges is the other part. Then organizational culture and leadership. Everything we say emanates from the top and it comes down. So even in the reverse format, when somebody from the down says, these are the problems, does the leadership in turn respond to what has been fed into the system? Do we give them an opportunity not to have a punitive method of being able to understand what they're saying? So these then impact the coordination and the transition of care from the acute intervention that the patient has gone, and thereby the inability that we have today to capture it in its whole in an audit becomes the challenge. So the challenges, and this is the second part of what I'm coming to, the challenges require today a multifaceted approach that the system not only reports, you audit it, but the learning systems out of that auditing should be in such a way that if you look at the Vanderbilt way of making things happen, then there is a chance that the audit in today's environment will have that impact. And I'll circle back as far as that is concerned at the end. Patient-reported data is very rarely looked at. We all have infection control, patient safety audit. Do we in our hospitals, have we got that culture in which you have a patient monitoring committee in which stakeholders from diverse places, including patients, is there, right? So today, you've given so much of empowerment to the patient to be able to follow up on his medicine, to do his physiotherapy, to do everything at home. But we don't have a system by which the information which comes to from the patient is then audited and then it is implemented in its true form. So these are very complex interactions. Also, given the very varied patient population you have. Today, we have international patients. We have patients from all over the country in every part. It's not only Delhi which will be like that. Mumbai will be like that. Small cities will be also like that. We have absolutely no methodology of capturing those nuances which directly impact patient safety, right? And infection is one of the biggest issues that we all deal with. Measurement tools and systems are all geared to the traditional way in which we have a standardized method of looking at patient outcomes. What is the average length of stay? What is the readmission rate? what is the impact as far as the antimicrobial biograms are. But these nuances we totally do not have a way of making happen. And they are equally important contributors to the whole journey of patient safety. You get admitted into a hospital, there is no way of knowing that when the patient has come and the caregivers have been told, and they in turn demonstrate back that they know every button that there is in the room. And galti se kisi ne kuch daba diya. So what it is required is that we need to have some collaborative research, validation, and then make tailor-made approaches to address this. And lastly, I would like to share, Sunil, is that
Yes.
it's about time that we had what we call patient monitoring committees. It's extremely challenging. It's extremely challenging to have that because you have to ask yourself how much do you want to have them within your system to understand it, because there are so many nuances to it. Advocacy in education, communication in healthcare professionals in a proper manner in which they don't feel, oh, even a patient proms will not turn down and tell you what the real problem is, because they know they have to come back to the hospital. They don't want to make enemies out of anybody. So you lose crucial information to be able to make it happen. So what are the tools? How do we approach it? I'll stop here because I think I've taken more than enough time. And maybe in the second round, we will take it forward. Back to you, Sunil.
Yeah, thank you so much, Dr. Shabnam, for sharing your valuable insights. You have very well outlined the objectives of this subject and also the challenges which we are all facing day in and day out, and the importance of post-discharge care or the continuum of care. We all talk about safety within the hospital, but after discharge, what happens to the patient? That part, I think the continuum of care is equally important. Also, you very rightly mentioned about the communication breakdown, which is, of course, communication is the key role of caregivers, which is beyond the hospital, and many other points. I think we will further interact, and questions will be asked me after all the speakers have done their job. So thank you very much, Dr. Shabnam. Now I will move on to Dr. Bansidhar Tarai. Dr. Bansidhar has already been introduced by Jaya. He is an associate director and head microbiology and infection control at Max Hospital, Saket. So, Dr. Bansidhar, your point of view, please share your insight on this subject.
Thank you, sir, and thank you, Jaya, for inviting me such a very wonderful discussion. So, sir, if you see the infection control, Dr. Sapnam Singh has already mentioned, the infection control is very a core of the hospital safety part, and it is not directly, but directly as well as indirectly, both involving the patient care, and it is also very important to the clinicians, the primary clinicians. They are very much concerned as well as for the patient care also. So if you see why actually it is very important, the most important part, especially in Indian scenario, is that we have a very uh, uh, high resistance of MDR infection. That is the most important part, because once the patient is getting the MDR infection, maybe MRSA or CRE, mainly we have a gram-negative multi-drug resistance bacteria, and for that we have very limited antibiotics. We have very, very limited antibiotics, especially in India and Southeast Asia or Asian countries, and that's why it is very, very difficult for us, for the clinicians, as well as for the patients. So we have to have a center like infection control. We have a structure part in each of the hospitals, our infection control committee, whereas we have an infection control team, which is including the infection control officer as well as infection control nurse, and the clinical support team, the clinical heads, as well as the support team is very, very important, like the nursing head, the engineering head, the housekeeping head, the pharmacy, clinical pharmacist, as well as the F&B. These are very, very important of the structure infection control committee. So we mainly our objectives is to basically to control the infections, control these MDR infections, because once the patient have MDR infections, so we'll have a multiple antibiotics and patient will have to stay for longer time, and then gradually patient's morbidity, mortality, everything is all depends, and there will be a cross infections as well as there is a chance of outbreak. So for that, the audit is basically we have a different in infection control practices. We have a daily rounds. Clinical rounds is very, very important, where a microbiologist, like if you say my examples, every day when there is a culture positive in morning when I report, I usually take a note of that in ICU and go start rounds and rounds. So we have almost 15 ICUs, I rounds for almost 3 hours and give advice which patient is culture positive, which patient is culture negative, what antibiotic to be given, which antibiotic to be stepped down. So this is a part of a routine clinical rounds and audits program is there. So in that way, what Dr. Sunil sir is saying and also Dr. Sapna was saying is the communication is the most important in patient safety programs, all the committees, whatever may be, because we have a high level clinicians, top level surgeons. How you communicate to them, how our rounds should be effective so that they trust on us, how we take care of their patients every day. I go rounds and inform them what antibiotic to be given, what's culture positive. This is very, very important. So that one rapport communication was built up, then it will easy for our infection control team or our all our whatever SOP or implementation part, then it will be very, very easy for us. Similarly, for the infection control nurses. So ICNs also have a audits process. On daily basis audit process, we have a separate team for the audit, for the antibiotic audit as well as the infection control audit. But as a daily rounds, they have a checklist where they have to audit the hand hygiene. It is the ICN's observation or audit which we take as a audit monitoring, that is the on the hand hygiene compliance what we take. It is the direct audit of ICNs of how many observations they have come across in the last 1 month. We take that as a hand hygiene compliance rate. Similarly, they also audit all the parts of the ICU's corner, the cleaning disinfection part, as well as the changing of all nylons or whatever those parts or all the bundles compliance, everything. So these they are the daily rounds. So this is very, very important on the audit process. Although we have a separate audit checklist, but daily checklist, daily rounds is more effective than the audit done by after 1 month or 15 days. That is my observation and my thinking of work. And we have a very strong daily audit programs. Our ICNs, especially for the communication part, I am saying they are not much afraid. I'm still in 15 years in the Max Healthcare. We don't afraid. It's because our ICN has been told that they can stop the clinicians if they are not adhering to our infection control practices or hand hygiene practices. They meet all the primary, mainly the top clinicians every 1 week or 15 days. I told separately they have to meet the top surgeons and explain what are the audits, what are the findings, what we have done, and how we have closed all the points. That is very, very point important for the infection control practices. Now coming to the the risk assessment. So basically, infection control risk assessment is a very important things, and it is coming up in the NABH and JCI everywhere. So we have a different risk assessments programs or schedules, but what we follow is that HIRA, that is basically hospital infection control risk assessments. So we have a different points, like what we target is that procedural issues, that is basically all procedures related. It may be device related infections like VAP, CLEPSI, COTI, or surgical site infections, or equipment associated or cleaning disinfection. So my thought on this, that whatever the hand hygiene practices, the hand hygiene is equally important is the cleaning disinfection. If an infection is happening, so hand hygiene is 50% to be blamed, and cleaning disinfection is up to 50% to be blamed. Only hand hygiene cannot prevent the infection, especially the MDR infections, which we are already covering in our countries. So if you give an example, suppose there is a risk, how we go through this, that we go, suppose example, surgical site infections, we audit them. So we basically check how many of them who are undergoing surgery, they have chlorhexidine bath taken previously or the day before the day of the surgery. So this we audit and we take a data, because if you see Staphylococcus aureus infection, surgical site infection, 95% to 100% can be reduced if a proper chlorhexidine bath is required. Gram negative is different thing, but usually Staph aureus or Staphylococcus is the most common surgical site infection. That can be reduced if there is a thorough 100% or 90% to 100% if there is a chlorhexidine bath twice before the surgery. Second thing is that what we audit is the surgical antibiotic prophylaxis. Is they take before right time, within half an hour or 1 hour of the surgery or not. If they are following the proper antibiotics, surgical antibiotic prophylaxis, what we basically make the antibiotic prophylaxis, will come to the AMR part and separate things, but we have a separate how to make these SOPs or things. So this is the, suppose we have a basically procedural issues, we have internal things or external, like we have a MDR infections, MRSA, CRE, Clostridium, H1N, COVID. So we have what we are doing the emergency preparedness, like we have a emergency preparedness for Ebola or COVID. So high risk infections, we have a very checklist on that. We have external exposure, like the rate of transmissions. Suppose a patient who have a high risk of infections coming to the emergency, we have a checklist. If the patient is a high risk of MDR infection, tuberculosis, or H1N or COVID, like we start from the beginning itself, if the patient will be shifted to isolation, or we have a separate cluster room where they can be transported there. So we take our surveillance of high risk areas like the OTs and the procedure rooms. Procedure rooms. So we have categorize then exposure in the hospital, like we have a sharp injury, the biomedical waste, all these things we have a separate audit process to check on daily rounds. So basically we more focus on daily rounds, and then the building, the construction part, engineering is a pre-risk. Take the construction, whenever there is a construction, they have to follow the risk assessment for the checklist part. Then we have a community outbreak where we have to have a fully preparedness for like the newer viruses or pathogens. So this is the basically the infection control part. So if the time permits, we'll have a second the AMR part and the MS programs. Sir.
Okay. Thank you, Dr. Bansidhar. You have very nicely elaborated the role of infection prevention and control in ensuring hospital and patient safety. And very nicely you mentioned about the team, the infection control nurse, the infection control officer, the support team, and also the constitution of this infection control committee. It all should be part of infection control committee, not only the clinical, even the support team, the engineering, the dietary, the housekeeping, CSSD. I think everyone should be a part of the infection control team, and the risk assessment. And one thing I really liked, you had that HIRA, you just mentioned, hospital infection risk assessment. or HICRA, I don't know, Hospital Infection Control.
HIRA.
HIRA, okay. So that is something which you have already implemented. Hand hygiene, surgical antibiotic prophylaxis. And one other important aspect which you mentioned about is that whenever there is a renovation work or construction work going on in the existing hospital, we need to involve the microbiologist, which we don't do. And microbiologist has to be a part of that project team whenever any renovation work is going on. So that's very important. You mentioned important point. And thank you, Dr. Bansidhar. And I would now like to switch over to Captain Sandhya Shankar Pandey, and she has already been introduced. But once again, I'll just mention Dr. Sandhya Pandey she is the Corporate Chief of Nursing, Medical Strategy and Operations, Fortis Group of Hospital. Over to Sandhya.
Thank you, Dr. Sunil, and big thanks to NATHEALTH, Jaya, for creating this opportunity, because this is not much spoken. And, its attention is now getting drawn more towards risk management and safety, quality, the more it is getting strengthened. And I certainly, I can say that the accreditation board in the country is leaving its impression and penetrating deeper in the healthcare. And so is this today's forum. So thank you so much for bringing them. Just a quick check. Am I audible, Dr. Sunil? Am I audible?
You are audible, but you are not visible.
Not visible. I am.
Anyway,
All right.
anyway,
I'm
fine.
visible on the
Audible.
screen. Am I? My video is on. Jaya, can you quickly confirm?
You are visible.
All right. Thank you. Fine. So very well brought out, Dr. Bansi and Dr. Shabnam, on various aspects of patient safety. But I would like to draw attention towards, when we talk of healthcare in our hospitals, the picture is a little bigger on the hospital safety. And I'm going to talk a little bit about hospital safety audits, because we play a critical role in it. And of course, patient safety is certainly a subset of the same. But in addition to, when we talk of the patient safety, it's the IPSG is the first thing which comes to our mind. But the picture is little bigger, it's larger. We as administrator and caregiver, direct caregivers, have a bigger responsibility and a role to play. So my further, few minutes will be spent on talking about hospital safety audits, its components, and the checklist. Of course, it would be available all over the Google, but there will be some tips which I would like to share. And of course, the role of caregivers and the largest workforce, that's the nurses, they can play in the hospital safety. And most importantly, I'll be touching upon how this information of the audit findings to be cascaded to the teams, to the workforces, to the frontliners and the other caregivers, which should work in the benefit of patients as well as the hospital employees. So in addition to the extensive infection prevention and control aspects, there are a few more important components which comprise the hospital safety framework. And this include so anybody who's, be it the quality, be it the medical administration, the operations team, or the leadership, when they put their heads together in designing the framework, the key components include the physical environment, and primarily it should include the facility layout and design, and as well as the safety signages. And I'm going to talk the critical ones which play an important role here. So along with the physical environment, it's the emergency preparedness in the hospital. And when we talk of emergency preparedness, the key ones include the fire safety, the natural disasters, infection control, infectious diseases, outbreaks. And the fourth one, the management of violent patients and any other emergencies which the hospital identifies. But these are the key emergency response plans which are to be assessed in terms of their drill and training. Infection control, it's already spoken at length, but special point on practices on the isolation protocols and cleaning and disinfection. While we talk of cleaning and disinfection, it's not about the method, mode, complying to the turnaround time, the TAT for the cleaning, disinfection, and readiness of the area. Most important is the dilution. Today, viewing the brands and variants and varieties of disinfectants available in the market, it's very important for the infection control nurses and the team to be aware about the dilution and, of course, preparation of the solution by the housekeeping or the GDA in the hospital under supervision. So this is one of the gaps which comes and emerges, which plays a key role in the break of the infection control chain, and it's very late to be discovered when it gets discovered. Next, after infection control, it's the medication safety and about the storage and handling of medications. And not only storage and handling, but also the labeling and their placement and dispensing of medication in the hospital. Next is the patient verification during the procedures. And then after that, from the patient aspects, coming on to the access control, as well as the security personnel trainings, and followed by the medical equipment safety. Now, medical equipment safety, much as it means a lot is spoken by Dr. Shabnam, but along with this, most important is the frequency, compliance to the frequency of calibration of the equipments, be it, and most importantly, the critical equipments in the wards and ICUs. So periodicity and the compliance to the frequency, and the biomedical waste management. Apart from the biomedical waste management, going on to the people, that the workforce or the caregiver or the healthcare professionals in the hospital, it's about the staffing and their workforce safety. Now, involvement of the stakeholders, that is the like Dr. Shabnam mentioned about a multidisciplinary team putting their heads together, designing the framework, but most important, the most ignored lot, the nursing representative or the nursing spock. Although seen in the good hospitals, but majority of the hospitals, it is assumed, it's taken for granted that everybody knows nursing. But it is an urge to please do involve the head of nursing or the representative from nursing, because it's not about counting the head count for the patient safety. It is about having an insight on the right skill mix for the patient care in that category or specialty of the hospital. So the levels of staffing as well as the workplace safety for the caregivers. Next, coming on to the engagement of patients and family. In that, most importantly, it's about the communication with the patients. And it's the patient counseling, again, a multidisciplinary counseling with their frequency and periodicity for the patients in the critical care and the long stay patients who are placed in the wards. And another thing in patient engagement is the patient education, followed by the compliance to the clinical policies, SOPs, and the guidance documents. And most importantly, the compliance or the late protocol and compliance to the data security and its privacy. Last but not the least is the regulatory compliance. And in this regulatory compliance, it is about the healthcare personnel and their mandatory credentials or the mandatory competencies required. For example, the registration of doctors and nurses, depending on the state regulatory norms, registration of the dietitian, the pharmacists, and the physiotherapists who are on roll and who are providing care to the patients. And apart from registration, the mandatory life support training and their capability of demonstrating the skills. So it's more important. So while these form the critical components of the hospital safety or patient safety framework, another important aspect is to be kept in mind is while we prepare the checklists for the doers and we train the auditors. Now, while we train the auditors and so designing the checklists, here the awareness of previous audit and their findings is important. The learnings and the challenges from the previous auditors is very much required to be incorporated in the checklist, and training of the auditors on the checklist is something important. And it should be something more and more of objective, but there has to be a space for the subjective finding to value the input and efforts of the auditor. So a remarks column is something very important irrespective of we use a manual or a digital form. And going from the checklist, its implementation is certainly, it's something, lot of methods and formulations and strategies are mentioned and taught in the not only as small as nursing administration classes or the MBA sessions, but more importantly, here is who is going to do the audit. And so the people who are, and again, there is, it's not necessary that it has to be a trained doctor or a trained graduate from the healthcare management, but the hospital nurses, any good front, maybe a person from the billing department, person from the compliances, or person from the or pharmacy, so on and so forth, anybody who is actually has got a deep sense of analysis, critical thinking, knack for learning, and inquisitiveness, and most importantly, awareness of the hospital processes and protocols. But coming on to the last aspect of my point is cascading of information and role of the caregivers in hospital patient safety audit and the hospital audit findings. Audit is done, analyzed, the data is collated, interpreted, inferences are drawn, and beautiful CAPAs go and get filed and presented and discussed in the committees. What happens on ground? Why the breaches take place and why patient complaints do not end for the same reason recurrently and periodically? There must be some reason. It's the person who is touching the patient is the person, he or she is aware of the gaps which have been identified in the process, or the challenges which they actually got caught while showing, performing and being observed as a deviator by the auditor. So in this, I think the most important thing, and as what Dr. Shabnam brought out, is communication, breach in communication. So breach in communication is not limited to the handovers between the doctors or between the clinical teams, training teams, shift handovers, transfers in the department, but and most importantly, it is the cascading of the information which comes out from a certain advanced activity. These audits are an advanced activity taking place in the hospital. How the findings are simplified and cascaded to the team members of every level, be it the frontline nurses, frontline housekeeping or GDA or a housekeeping personnel, or a resident doctor, who are, and these are the core stakeholders and drivers of the patient safety. So last section on this, on what role, and the most neglected lot, I would say, not neglected, but the ignored lot, is the nurses, the largest workforce, who from the designing and conceptualization of this entire framework till the carrier and driving and implementing on ground can play a critical role at every step because of their visibility, accessibility, availability, and knowledge base. So, and the domain knowledge. So I would talk about the role of nurses in the patient safety audit, but not narrowing it only to the nurses. The same is applicable to everybody. Those who touch the patients in the journey of patient care. And so nurses can serve as an frontline observers. They are currently in majority of the hospitals in India, in public or private sector, they are the data feeders, data collectors and the data feeders. It's time now they become the data managers as well. The concept, it's evolving, but it's a way to go. Adherence, they are the ones who knows what is to be done to adhere to the guidelines. Probably they are the ones who need to be empowered to inform the resident doctors, pharmacists, physiotherapists, dietitians, and of course the housekeeping personnel. Be it the medication safety, if a medication audit is to be done, it's the medication administration process is to be performed in the tracer method, and we come to know the entire process prevailing in the hospital, which can breach the patient safety. Patient and nurses can talk about and are aware about the patient identification and related communication in the form of verbal and written documents, be it infection control practices, incident reporting, their root cause analysis, staff training, their competencies, engaging with the patients and families in educating them, and of course, proving to be key frontliners and the torchbearers in the driving the patient's safety culture in the hospital. Probably the bullets which I just mentioned now are all driven single-handedly by the nurses. Yes, I don't deny there has to be a degree of empowerment and support by the leadership where they can flourish. And when those situations, sky's the limit. And when we talk of action planning, implementation, we talk of continuous improvement. And friends, today's buzzword, sustenance. Now, what continuous improvement, quality planning, as well as the sustenance. When we talk on these things, probably nurses can prove to be the key stakeholders and the drivers for these initiatives. Within the paucity of time, these are only the headings, but they themselves are a big, subjects to be spoken and topics to be dealt with. But of course, this certainly, quoting these bullets will raise a trigger and give you an insight on what all can be done by this largest workforce and specific domain in the hospital. And these are the advantages when we talk of patient advocacy, patient involvement, and patient going, confident in talking and participating in their journey of care. Over there, the nurses can play a critical role in giving confidence to the patient that yes, they are partners in their journey of their care and their treatment. They are the connecting link between the doctors and the nurses. And that's why you will relate from your clinical settings. The doctors, the pharmacists, physiotherapists, the healthcare personnel, those who communicate really well. There is content and whole completeness in their information, are one of the best and the most closest to the patients and their caregiving teams, and are most successful ones. That's all I conclude. Back to you, Dr. Sunil. Thank you.
Dr. Sunil, you are on mute.
Okay. Thank you. Thank you, Sandhya. You have spoken it all, and you have very nicely touched upon all aspects of patient safety. And you are very passionate about the role of nursing. It's not only about nursing education, nursing engagement, but nursing empowerment as well. So I think, and very rightly you mentioned about the sustainability. So we need to look for a sustainable solution. We need to involve all the stakeholders. The major chunk of the team in the hospital, the nurses, which according to you, which are the most neglected lot, who are not involved. But I think engaging nurses, empowering nurses should be, it's a part of the strategy. I mean, when we talk about the safety in a hospital. So thank you, Sandhya. Thank you so much. Now I have a couple of questions for the speakers because we still have some time. And my first question is to Dr. Shabnam. Dr. Shabnam, you mentioned about the communication failure, that is, communication breakdown, communication barrier with the patient, not only the patient, caregivers, and all stakeholders. So what mechanisms we should have, communication mechanism to improve the communication part?
So when you look at the pyramid of communication, Sunil, the first most important part of communication starts at the bottom. And I think to some degree it relates to what Sandhya and Dr. Bansidhar also said. The first communication should be such that people are so comfortable with the culture of the organization that they can informally share that communication or share their concern about safety from all the aspects that both have spoken about to their immediate peer. So you have to build that comfort level that when I communicate my concern about patient safety, which I have observed, there will be no repercussion, right? Now, look at it from the receiver's perspective. So the receiver gets this information. How do they send it up the value chain, right? And what is the response in the organization to that comment or that narrative which then is not, it is taken to the second state of communication. Okay, I've heard what is wrong, and in that piece, I will have an informal way of sorting it out, right? I'm not going to be punitive. And then you give it time for it to settle. If it doesn't, then you take it to a level up, wherein that there is some disciplinary action which is embedded in the protocols of the organization, right? And this education and this knowledge, again through the culture of the organization, comes down, as Sandhya put it, in a cascading way. And then finally is the punitive action, right? And the punitive action is such that it applies from leadership downwards. So when that culture comes into the organization, right, that I'm not scared to say something that I have found in an audit or a patient has shared with me, right? That feeling of safety. So one is the safety audit, but in the safety audit, as both of them have said, you pick up the nuances, then you have to correct them. So when you have to correct them, it has to be through people engagement. And when it has to be through people engagement, you have to make this culture form in the organization. And only with that culture and engagement, and this has to be repetitive. It's not a one-off. I did it when a person has joined the organization and then I've forgotten about it. It's lying with the books in dust. No, it has to be constantly repeated. Then that's the way it'll happen.
Thank you so much. Very nicely answered, Dr. Shabnam. I think we have to be persistent with this, in developing the communication skills and communicating and engaging patients, caregivers, and the staff. That's very important. Next question. My next question is to Dr. Bansi. Dr. Bansi, you mentioned about the risk management plans, right? So can you share some examples of the successful risk management plan which you have, implemented in your hospital? Can you share your experience with us?
Yes, sir. Yes, sir. So basically, we every year at the beginning, we have a goal setting as well as the risk assessment plan for the whole year. So suppose let me example of the VAP, COTI or something like this. So we have, if you have a very high rate, so yeah, so SSI also. So we have a risk, we make a risk assessment. So where is there is, suppose if there is a epilepsy, so where is there is a 5 or 6 points, where is the majority of the things can be assessed. Like we evaluate the last year data, if there is a suppose SSI also, this is patient on diabetic are more prone for SSI or chlorhexidine bath, or there are 5 or 6 points. We take as a risk assessment goal and do a project, and then at the end we see there is a reduction in the our HI specific to the one HI, or can be of MDR infection also, like even our MRSA or CRE. If there is a such a things, we have a basically a score. So if that score is a little higher side, so we take as our next goal for the next year and make a risk plan and do the thing.
Okay, wonderful. And coming back to you, Sandhya, coming, I mean, this is from the risk management. We talked about risk management by Dr. Bansidhar has spoken about that. And, from the risk management plan perspective, I'll ask you, how can we engage patients in the risk management plan? I mean, how do we include patients in the risk management?
No, thank you so much for asking this question to me, because this is again a newer development, a recent development, where nursing risk assessments and patient engagement in risk assessments and risk management is something which is emerging in a very strong way.
That's right.
So while we have focused on nursing risk assessments, and nursing is all about care, so relating care and to the communicating care to the patient and involving them in their care activities is something, their involvement in their risk management. And I'll explain this with one example and scenario. It will clarify. For example, there is a patient who is at very high risk of fall. The Morse fall risk assessment has given a score of 48, and patient is at high risk for fall, and the medications who can trigger fall, and patient is on diuretics. When the nurse does this assessments and she finds that patient is on high risk, communication to the patient and the relatives is more important, which is going to be very impactful, because I'm running this pilot for last 6 months and it's working well for us.
Wonderful.
Communicating to the patient that you are getting some medicines because of this X condition. Doctor has prescribed this for you, and these are the timings because of which you are at which you will be getting. So this is the duration. If you just suddenly get up from the bed and you walk alone towards the bathroom without calling for help, may induce fall, because you are likely to feel giddy. You will feel dizzy. Now, this has helped. This communication, this word, and patient, it gets, pinned in his head, in his memory. That, and then they started to ask, what do we do? It's another opportunity for the nurse to engage them. Hang your legs, count 10, or ask for help. I'm around, and then go to the washroom, or go for your elimination needs. So it is something involving patients by communicating honestly, transparently, but in a professional manner. Not like this.
Okay.
आप बहुत high risk score आपका बहुत ज़्यादा आ गया तो आप गिर जाओगे. No. So in a professional manner, so there is an framework which is required on this, and this is how nursing risk assessments are the direct gateways where the hospital team can make themselves aware, and then empower and encourage nurses and train them well to communicate in the right manner about the care related concerns to the patients and families, and involve them in their care. So this certainly will do wonders.
Thank you, Sandhya. I think since that we are running short of time, I'll ask one more questions to each speaker, and then if there are any questions from the participants, we'll take up those few questions. My next question is to Dr. Shabnam. She touched upon the patient monitoring committee. She did mention that the committee is there, but it has to be more, it should be functioning. The effectiveness of the committee, the functioning of the committee is not proper most of the time. So how do you ensure that the patient monitoring committee, it functions properly, and then we take further action based on the findings, monitoring findings?
So I think firstly what is required is we have a traditional methodology of patient safety, infection control committees, mortality, morbidity. We have all of this. Now, this is a fast growing and an understood scenario because of the gamut of services in healthcare delivery. Rather, put it another way, healthcare delivery being done not only in the hospital, but in home care, in other settings, that everybody's mind is opening up. So firstly, the nomenclature, either you can have it as a separate committee, that is a patient monitoring committee, right? And in the oversight, you have the traditional ones. Then you have this where there is a place for a much wider set of people. So it is like saying you have a committee now where you have patient advocacy groups, you have patients themselves who are part here. And now this, as I said, is a very delicate situation, because at the end of the day, you're going to review adverse events. You're going to see that there have been near misses, right? How engaged or how responsible is the receiver of that information, willing to take that in the lens of making an improvement or bringing an innovation to solve for that problem, right? So it's a very nuanced way of addressing it. The other is the complexity of the context in which you are. So if you have a hospital which is predominantly in a tier 3 city or in a tribal area, and you apply a patient monitoring system, which is in Fortis, Gurgaon, for instance, or a Max Hospital in Saket, the twain shall not meet, right? Because the cultural, social issues which will feed into patient safety are extremely diverse, right? It's like yesterday, a couple of days back, it was Hepatitis Day, and they had this little skit in which they're trying to tell people, do not have anything in anybody. Your neighbor comes and you say, Giloy pila do isko, and then the person goes and has a crash, right? So you have to be very nuanced in it. Take baby steps would be my advice. Don't rush into it, but make sure that that level of patient engagement is is slowly weaved into the system. I recall when we started Max Hospital many years ago, we realized that the most important person in the entire journey of the patient was the valet who did not bring the car on time. You could have done whatever you wanted as far as the patient was concerned, but Gadi time pe nahi aayi, the feedback that came it was a terrible experience. So these are the kind of contexts which you need to have. You have to sift through this. So the people who are sitting in that monitoring committee should have the depth of understanding the context before you bring them into the system.
Wonderful. Thank you. My next question is to Dr. Bansidhar, quickly, because we are actually we have just overshot the time. Dr. Bansidhar, you mentioned about the clinical rounds, routine or the daily clinical rounds, which is very important. And what are the parameters? Just quick to tell me 4 or 5 parameters which you look for when you go on rounds with your team. So what are those parameters? And most important aspect of any survey or any monitoring or rounds is the data collection. Very important, because the data has to be collected properly and then analyzed and do the RCA, of course, and take corrective and preventive action. So that completes the whole loop of quality improvement, when we say. So what are those checkpoints or quick parameters which you look for, your team looks for?
So basically, regarding the data collection, so what we have introduced the digitalization process. Initially, our ICNs go into the every bed or come to the microbiology and take all the data. So from 2013 onwards, we made completely digitalization of the HI as well as the AMS programs. I think almost 10 years back. So we have tracked all the HIs, clepsy, coti, VAP or SSI. If the patient is on ventilator and 48 hours after any culture positive, it will directly come to the ICN from the digital tracking, even central line as well as catheter.
Wonderful.
So first step is that we the manual work we stop, because there are two merit or demerit. First, all clinicians are saying we have compromised our data, we have notes, audited all the points, all the HIs. So, but we made complete digitalizations. We made digitalization on the AMS program. We have started the DDT consumption, antibiotic consumptions of all the hospitals. First, we have Saket, then all the hospital and compare the DDT data. Then we have started the drug resistance index, DRI, for all top 5 organisms. That also we have digitized, or at least the most important, the tertiary hospitals, the antibiogram data, as well as the antibiotic policy, surgical antibiotic prophylaxis, everything we made the MS mobile app. Also, we have made the browsers website where our ICNs, initially the ICNs and we microbiology also do the prescription audit of all restricted antibiotics and the higher antibiotics. So we made a complete digitalization process. So that's why my rounds is little different. I usually go for a clinical rounds to all the ICUs and review all infected patients and start antibiotics or de-escalate the antibiotics. ICNs take a separate rounds to review all the infection control practices and checklist and put in the registers. But we maximize the digitalization process. Not only this, there are many things which you have digitalized. If the patient is on surgical prophylaxis, after 48 hours, it automatically from the system CPRS, it will say you have to stop. It is already 48 hours. If you want to continue, you have to say the reasons. Even the restricted antibiotics, if they order, the pharmacy will not give unless they have to justify what type of risk category of patients is this. So we have made a streamline on the digitalization part. I think that time none of the hospital in India or even world also was doing this digitalization process. We have. So
Okay,
this is our.
thank you, Dr. Bansidhar. Excellent, because digitalization is the key. Digital health, role of technology is so important, and definitely it improves the efficiency, improves safety, and of course improves the outcome, and also reduce the cost. So this is the role of digital health. And my last question now is to Sandhya. Sandhya, just enumerate, just highlight something on the international patient safety goals. We have these patient safety goals. Everybody talks about, and nurses should be aware. Everyone should be aware of those goals. So how important these goals are, and whether it should be part of the hospital safety program, because we need to have a comprehensive hospital safety program. We should include all aspects of safety, which we have discussed. We have been discussing since last 1 hour. So just touch upon the IPSG and the safety program quickly. Yeah. You are mute. You are mute. You are mute.
Thank you, Dr. Sunil. Safety, I don't deny. Yes, safety, the moment patient safety comes in, it's the first thought which has come when the concept of the word got coined was IPSG. And when it's a IPSG, and please follow it in your hospital, only one domain or the department is thought of is nursing, because every IPSG it's actually thought, and it's right now the impression in the healthcare that the nurses have to do. If the nursing is not there, they are not doing, means IPSG is not complied. I would say that is the accomplishment of this department or this IPSG. But what is it? It is actually talking about each one of them. Now they are the ones who are the key drivers, and why only these 6 IPSG goals, be it related to identification of the patient, be it the communication, that is the handovers, or any other transition of care between the 2 caregivers, be it related to medication safety on high alert drugs, be it related to surgical safety in terms of the in compliance to surgical safety checklist, or be it related to hospital-acquired healthcare infections, or be it related to preventing falls in the hospital. So now when we talk of these 6 key areas, see, look at the other way. If these are 6 processes, they ultimately, in a broader sense, and narrowing it down, they impact directly the multiple care-related processes or safety-related sub-processes. And these sub-processes, if we map, they are somewhere between 40 to 60 of them. So it's the entire journey of patient which is there in the hospital gets directly or indirectly impacted when these safety goals are addressed meticulously in total. So that's the reason they are actually a domain in themselves. They are chapter, they are books, and they are actually an expertise in itself. And that's what I would I relate IPSG closely with. And addressing them is something not about talking about the big frameworks and patient safety, hospital safety. The journey and the care starts from the patients. And if we talk about it, take care of these 6 goals, their compliance in implementation and compliance in the hospital, your safety is taken care of as far as patients are concerned.
Thank you. Thank you, Sandhya. I think we have come to the end of the session. Before I conclude, we have a couple of questions. There are only 2 questions in the chat box. I think we'll take up these 2 questions quickly. One question is by Dr. I.S. Hura. Kindly inform whether pharmacovigilance system is verified during hospital audits. Healthcare professional training is conducted in the hospital for patient safety. So he's basically asked there are 2 components of his question. One is about the pharmacovigilance, whether it is should be part of the hospital audit system. And another one is the training part. I think training part has been answered, I think already addressed by the speakers. We need to have a robust training program as far as safety is concerned for all the components of the safety. So pharmacovigilance, who would like to answer? Is Dr. Bansidhar or Sandhya? Anybody who would like to answer?
Antibiotic part I can answer, but I think Sandhya will first.
Yeah, both of you can answer. Yeah, sure.
So as per my view, pharmacovigilance is a compliance and a mandate which for the hospital, right, internally. But as far as patient safety is concerned, your day-to-day audits and your framework should be more inclusive of medication safety. That is the medication management process. And pharmacovigilance will further include your incidents, your adverse drug reactions, and subsequent incidences, right? So more importantly, the safety audit is more about the process deviation and their related corrective and preventive actions. So Dr. Hura, the gentleman who has asked this question, the appropriate way would be to focus on the medication safety or the medication management when we talk of hospital safety or patient safety. Pharmacovigilance itself is a separate area to be dealt with for as far as compliance by the hospital is concerned.
Like for the AMS program, so we have a
you would like to add?
Yeah, for the AMS program, we do a lot of PKPD for the antibiotics. Like we see the creatinine clearance and the dose monitoring. So we have a pharma team so that they, or if there is an dose alteration as per the creatinine clearance, they immediately go to the patient side and say what is the dose. So we have audited all these patients who are on route. What is the dose of the antibiotic? What is the route? And what is the duration? Basically, the 2 to 3 hours, our barely the all beta lactam antibiotics should be a slow infusion. Most of the hospitals or patients, they don't do receive slow infusion. So we have a lot of pharmaceutical antibiotic audits protocols are there, the surgical prophylaxis and all the things. But more of the I think adverse reaction or other things are very important.
Yeah, thank you. And there's another question by Mr. Arif Khan. He asked about the quality improvement in dialysis units, in dialysis. So how do we improve quality to ensure safety? So Dr. Bansidhar, I think if you can answer.
Yes, sir. So we have a lot of
dialysis unit.
Dialysis. If you see the patients who are
high risk area, it's also a high risk area.
High risk area.
When we identify high risk areas, so dialysis is one high risk area.
Is very important. Dialysis is very important, sir. Especially in ICU, if you see the dialysis in the port, the dialysis most important is the RO water. Where is the port is lying? If the port is lying in the nursing stations and there is a long pipe and the patient was extremely end of the ICU, then there will be a lot of breach in the dialysis process and there can be lead to infection. So we should have a double port or a double RO port, and mostly there should be a portable like in each bedside or at least in each ICU there are 4 points where the dialysis machines should be kept. The most important point is this, because we have seen one outbreak of Acinetobacter. This is because there is a one single port line and where the dialysis was kept in the nursing stations, and from the nursing station the infection spread to the extreme end of the patient was lying, and there is a long pipe and there is also there a lot of tapes are there to that leakage area. So this is the most important point in the hospital setup. Second, we have a checklist, different checklists, how the dialysis machines, the dialyzer, lot of things where how we have to do the surveillance culture as well as the clinic disinfection part is most important is the RO. RO is the most important point where the dialysis to be important.
Wonderful. I think thank you very much. Now we have come to the close of this insightful session, and I'm really impressed by the knowledge, the wealth of knowledge by our esteemed speakers. Patient safety is not just a goal, it is not just a goal, but it is a shared responsibility which involves the collaboration at every level of healthcare. And the emphasis should be on the culture of transparency, culture of communication, proactive approach to risk management. So let us remain committed to the pursuit of excellence in patient care by ensuring patient safety And I extend my sincere gratitude to our speakers for sharing their expertise, and to all of you who have participated in this webinar. And we are now much wiser. So the take-home message is that patient safety is the fundamental, and everyone should be part of this activity, and it has to be a collaborative approach. And not only at the hospital level, patient community, it has to go to the community level also. Education, engagement, empowerment. Also, with these, I end this session. And once again, thank you, speakers, thank you, participants, and thank you, Jaya, for being a lovely moderator. Being a lovely coordinator. You have been coordinating with us so well, and you were literally chasing us, to make this happen. And thank you, NATHEALTH, for this, and congratulations once again, NATHEALTH, for this initiative. And thank you all.
Thank you, sir.
Thank you so much.
Thank you, everyone.
So,
on behalf
Jaya, we should take a session photo, actually, group photo for this. Group photo.
Yeah. Yes. Thank you for reminding. Yeah.
Okay, thank you so much.
Thank you,
Thank you, sir.
everybody.
Thank you, everyone.
Thank you.
So, on
Thank you.
behalf of
Thank you.
NATHEALTH, I extend my heartfelt gratitude to each one of you for making this session a resounding success. A big thank you to you, sir, Dr. Khetrapal, sir, for skillfully
Thank you.
steering and moderating the session. And a sincere thank you to Dr. Shabnam ma'am, Dr. Bansidhar, and Captain Sandhya for delving into such a minute details of hospital safety audits. Your thorough insights are invaluable and contribute significantly to our understanding of this critical aspect. And a special appreciation goes out to our attendees. Your active participation and support have been instrumental in making this event a successful. So thank you once again to all of you, and we look forward to many more such sessions. Thank you.
Thank you.
Thank you. Thank you all.
Thank you.
Bye.
Bye-bye. Have a great
Bye.
evening. Bye-bye.
Thank you.
Okay.